Yeah, now I can see you. Sorry.
Let's start, Shobha.
Yeah. So, good evening to all of you. Good afternoon, rather, on this warm March afternoon at Bengaluru. And I think this year the summer is quite intense, and everywhere it must be feeling hot. So, on this hot summer afternoon, let us sit down to discuss some cool subjects. Today, we thought that in Sankalp we'll touch upon female sterilization and also upon some aspects of intrauterine device procedures and also on some new publications. I would like to first introduce or bring onto the stage Dr. Lakshmi Srikhande, the chairperson of ICOG. Can I have the PPTs, please, for the introductions, please?
Hello, good afternoon.
Good afternoon, madam.
Shubha, good afternoon.
Good afternoon,
Lakshmi,
madam.
good afternoon.
Madam, good afternoon.
Present, madam.
Yeah. So you have shared this thing, or this is mine? You have shared. Okay. I was also trying to share. So it is my privilege to introduce the chairperson, Dr. Lakshmi Srikhande. Madam is at present the chairperson of ICOG, conducting a fantastic year. Just now, the very, very resoundingly successful RRR was conducted, the annual conference of ICOG, and it was a splendid feast of academics and cultural events, and it was full of joy and learning. Congratulations, Dr. Lakshmi, for that. She is also the national corresponding editor for Jogi and secretary for Association of Medical Women India, founder, patron, and president ISOPAR Vidarbha chapter, and several such posts to her credit. She has been the vice president of FOGSI in 2012 and the Menopause Society of Nagpur in 16 to 18. And of course, she has headed the Nagpur OBGYN Society 2005 and 6. She has been awarded much decorated at the hands of very senior people. The Union Minister of Sri Nitinji Gadkari has honored her with Nagpur Ratan Award. Also the Bharat Excellence Award for Women's Health, and Mahrudara Insotia for Best Committee for her work as chairperson of HIV/AIDS Committee. The government also has acknowledged her work and has given an appreciation letter for her work in the field of Save the Girl Child. Highly creditable indeed, and very prolific orator, author, and very good number of publications. I think she has made her mark in the field of ART as well, and has taken very active part in educating the adolescent of Maharashtra. Thank you so much, Dr. Lakshmi, for the granting the past chairperson of Family Welfare Committee with the Sankalp webinar series. And it gives us an opportunity to bring forward the complex issues related to family planning and contraception. So the dais is all yours.
Thank you so much, Shobha, for your kind words and also for your appreciation to RRR. It was indeed a pleasure to have you as our national faculty during this annual ICOG conference. So friends, good evening to one and all. And I'm so happy that today we have come out with a theme of Sankalp webinar as setting context for quality FP, that is family planning services. I'm sure you all know that India was the first country to launch national program on family planning way back in 1952. And since then, it has changed its policies, and instead of focusing only on population stabilization, now it is focusing on reproductive health. And why we have chosen the first session as all about female sterilization? Yes, the numbers of female sterilizations are rising. According to NFHS 5, in the sterilization percentage in a woman is almost around 30 to 35%. Of course, it is more in rural women as compared to urban women, but still we are relying more on female sterilization instead of relying on vasectomy. which is far more safer and non-invasive. I was a freelancing laparoscopic surgeon, and I really realized the importance of difficult sterilization when I was not able to find out the another tube. In two such instances, in one instance, then the main gynecologist told me that she has ectopic pregnancy, so that tube is removed. And in another case, because of pelvic adhesions, I could not find and ligate the second fallopian tube. But good, I documented that and I explained to the patient, because she became pregnant after that tubal ligation. So I'm so happy, Shobha, you have chosen the topic of difficult sterilizations, and Dr. Prabha Desai will be elaborating on it. But following that, you have chosen Dr. M.C. Patel to speak on the medico-legal aspects of these difficult sterilizations, which is really very, very important. And who else than Dr. Meera Agnihotri and Dr. Srinivasan to give expert comments on this first session of all about female sterilization. Then second session is on about techniques and publications, and she has aptly chosen the video capsule on IUCD procedure demonstration. And in the publication capsule, we do want to promote centroman as a valid choice for post-abortal contraception, because this is an important window of opportunity to grab the attention of these women. Despite an enviable safety profile and dosing schedule, centroman remains largely underutilized, and we have to increase the awareness amongst women as well as healthcare workers. So aptly, we have chosen the second session. So friends, and this is followed by an interactive session. You all can ask questions to our experts. And the second session, we are having our chairpersons as Dr. Mrinalini and Dr. Susila to give expert comments. After these two sessions, we will be having interactive session. You can post your questions in the chat box so that interact freely with all our esteemed experts. I would like to place on record my gratitude to our FOGSI President, Dr. Rishikesh Pai, our Secretary General, Dr. Madhuri Patel, and I also want to acknowledge our Vice Chairperson, Dr. Parag Biniwale, Secretary Ashok Kumar, and our convener for this Sankalp series, Dr. Shobha Gudi, who is doing a wonderful work month after month, coming out with a fantastic module and with experts to speak on that subject. I like to welcome all the speakers, chairpersons, and dear delegates. So happy learning, and I am here also to learn so much from these experts on all about the sterilization, IUCD, and centroman. So once again, welcome you all, and I hand over back to Shobha for further proceedings.
Yeah, thank you, Lakshmi. I'll be sharing the screen now, Nilima, no problem. I would now like to welcome the chairpersons of the first session, Meera Madam, as we fondly call her, Dr. Meera Agnihotri. Madam is Professor and Head, GSVM Medical College, and presently Chairperson of Ethics and Research State Chapter, and President of WWF, the founder chairperson there, an advisor for Women's Health Cell, Ministry of Health, and she has organized several conferences, national and international, and the UpCon in particular is in Kanpur was a very well acknowledged conference by Madam, and actually the month of May will see yet another FOGSI conference guided by Madam. And she is very richly decorated. Madam has won the ICOG Ratna Saman and Golden Plaque in the 63rd AICOG. And she has won awards for Best FOGSI Focus also, and for Women Empowerment. Most significantly, she has had the Lifetime Achievement Award from FOGSI at Hyderabad, and also by ICES, and Women Empowerment Summit Honor at Delhi. Teacher of teachers, we present to you, Meera Madam. It is also my pleasure to introduce my dear friend and colleague from Bengaluru Society, Dr. K. Srinivas. I had the good fortune that Dr. Srinivas worked with me in Sankalp Family Welfare Committee projects. And also he was vice president for me when I headed the society in 2018 and 19. He has been a very staunch academician, written books for postgraduates, published a lot of papers, many chapters, and he is at present the professor of OBG at BMC RI Bengaluru. And I think he also stands in as HOD whenever the head of the department is not able to, be there. He's a very apt chairperson for this session because he was a committee member of guideline formulation for standards in female sterilization. With the permission of Dr. Lakshmi Srikhande, I would like to invite Meera Madam now to introduce the chairpersons and to give her thoughts on her work, her experience, rich experience in the field of family planning. And after the, I would also request her to introduce the first speaker. And after that, I would request Dr. Srinivas to introduce the next speaker, Dr. Patel, and both of them to conduct the interaction. So here is to you, Meera ma'am. After you speak, I will share the next slide for introduction.
Welcome, Meera madam. Welcome to ICOG.
I don't have anybody's biodata. So
Ma'am, first you speak about the family planning work
Okay,
that
okay,
you
okay.
have done for
It's a
2
matter of,
minutes, then I will share. Yeah.
Okay, it's a matter of great honor and pleasure for me to be a part of this wonderful meeting where who and who of the country are sitting over here, right from Lakshmi, Dr. Patel, Dr. Srinivas, and I mean one and all. Regarding my experience, you see at the outset, being a part of the government, you all must be reading these days in all the papers every day, although the opposition is criticizing it. There must be a definite guideline for population stabilization. So population stabilization has become a prime agenda of forthcoming government policies. And for that, we are all being invited to send our suggestions one after the other. And I personally feel that as far as our faculty is concerned, our paternity is concerned, I know that everybody is telling that the guidelines must be same irrespective of the creed, color, and caste. I can marry twice, I can marry thrice, I can have 12 children, I can have 11 children, you can have one only, and this and that. This is all being streamlined, and Lakshmi must be knowing it, and Shobha, you must be knowing that it is all in the pipeline, that we are trying to conclude that population stabilization with one agenda must be there, one country, one rule. I hopefully think that we will be quite successful. Regarding the family planning, if I go back into the memory of the lane, when I was a young lecturer, you see, medical termination of pregnancy was supposed to be criminal act, and we were not allowed to carry out termination of the pregnancy under any circumstances, except 1, 2, 3, 4, 5 like this. You can count them on the finger. Thereafter, in 1972, it became legalized. But for us who have never done MTP in our residency or early lecture, we were quite hesitant to do it, and so on. And you know that what is being happening, that a part of it was being taken as a family planning procedure. Medical termination of pregnancy, vaginal ligation, medical termination of pregnancy with ligation. And all of us are fully aware that we have done not only medical termination of pregnancy along with ligation, we have done lot big camps, 400 cases, 300 cases. We were staying in the remote areas for 3 days, 4 days, and we were doing it. Anyhow, thereafter, the village campaigns were, you see, folded back. Why? Because their mortality rate was quite high, morbidity was very high. So it was folded back, and we were allowed to do it in the. So when I joined as a professor and head, you see, they were in the process of winding up. And these camps have to be done strictly in the hospital premises, whatever number may be. So our village travel with a tent over it and घास फूस के ऊपर दरी लिटा के thousands and thousands of ligations being done is banned. Thereafter, vaginal tubectomy, a door of vaginal tubectomy, and we were trained. I was training for vaginal tubectomies, but that too has slowed down. And presently, all of you know that ligation procedures, technically, academically, and even socially, have undergone revolutionary changes in the present ethics. So I personally feel that today's subject, which is chosen by our ICOG head, is one of the most important things which must be told to the postgraduates, and guideline experts are also present. So I think we will go back with wonderful messages, with a long history right from Queen Charlotte up to this time, the way it was being done, the way it is being done. And we have all practiced one ligation, take out one has to be taken into the broad ligament, and so on and so forth. So we will be knowing the best of it. And I personally feel all of us must be with the government as far as this policy is concerned regarding the population stabilization. So thank you very much, Shobha. I really feel very privileged to be a part of it. And the person sitting over them, I salute Dr. M.C. Patel, Shobha, Dr. Srivas, Lakshmi, and my young buddy, Kavita, and Prabha. I can see only these persons and so on. So please accept my greetings and well wishes for the best performance of this thing. And I will very humbly request you to please pardon me to leave the platform, because in our this thing we have got a very important meeting going on which has already started at 4 o'clock, and from Pune this girl has come for lecture, and there are 2 sessions going on, and I'm chief guest over there. So I will very humbly request you to kindly permit me to leave this station, although I don't want to leave your lovely faces. But since I have to be present over there, kindly
Thank you,
permit me.
madam. Thank you for gracing our occasion, and
Thank you.
thanks a lot for
Thank
your
you very
kind
much.
words. Thank you.
Okay.
Thank you very much. Dr. Srinivas, can you unmute and say a few words, your experience, and then I will put the CDs for introduction. Yeah.
Good evening, all. Thanks a lot, madam, for this opportunity. I really view it as a privilege to be a part of this kind of session with all these national faculties. And more than anything, I think co-chairing with Meera madam is a great honor for me. And I salute madam for accepting me as her co-chair. That shows her greatness. And she has very nicely traveled through the evolution of sterilization from probably the way she was speaking. I think she was a postgraduate by 1960 itself, must be. So she has traveled over the past 5 or 6 decades, and sterilization I have seen in the rural areas, and also the sterilization camps that happen in the hospitals. And the camp approach and fixed day approach are the 2 approaches that were that are going on even now in certain areas. And just the fact that the government has removed the target oriented approach in sterilization performance has eased most of these things. Earlier it was a kind of force that if you don't achieve this target, the PHC medical officer would be punished, the area staff nurse would be punished, and we have come out of it. And it's thanks to the counseling techniques, like offering them with so many things. I think in Sankalp, madam concentrated more on larks. I was watching those things, and it's not that sterilization is the only answer for family planning. So, but while doing laparoscopic sterilizations, the recent trend with too many cesarean sections, some of the areas reaching 50 to 80%. Number 2, promiscuity causing a lot of PIDs in the adolescents or in the reproductive age group, and also the conservative management of ectopic. could be the cause for a lot of difficulties during laparoscopic sterilizations that we may encounter. Of course, as Meera, I think Lakshmi Madam was telling, I have also come across quite a few cases in which just I would like to share one experience in which I could not find neither the uterus nor the tubes. So I was going through all the aspects of abdomen, and then I just turned my laparoscope by 180° and the uterus was totally stuck to the anterior abdominal wall with hanging tubes on either sides. Right. So it was a previous 2-section case in which it was so firmly adherent. That was not a real difficult case, but still I was surprised to see that there was no uterus with my routine 30° laparoscope view. So there could be a lot of other difficulties that we come across, and I think without spending much time on my discourse, let Dr. Prabha Madam take over and go ahead with
I would require you to introduce her briefly. I'm
Yeah,
just
sure.
sharing her slide. Dr. Prabha again is from Karnataka. So,
Yeah.
Yeah.
So the speaker is Dr. Prabha. She's from Karnataka. She owns LYDM Sparsh Multi-Speciality Hospital, Gadag. I think we have met in one more session on tubectomy, if I'm right, a couple of years or months ago. And she is a member of IMA, FOGSI, IAG, ISAR, and she has been awarded with Golden Jubilee Award, Mumbai 2000 to 2003 for the best thesis. So this is from her studenthood itself. Best Academician Award of Gadag Obstetric and Gynae Society 2015 and 16. And she has got quite a few publications, most of them related to laparoscopy. And she is an invited faculty for various FOGSI programs and Beti Bachao, Beti Padhao. She has given a speech on NDTV, and her special interest is on gynec endoscopy, urogynecology, and she conducts free pap smears, of course, social service oriented doctor. And there is also something called Save Uterus campaign that she's doing. Yeah, great. And over to Dr. Prabha Madam. The dais is yours.
Yeah, please share, Prabha.
Yes, ma'am. I'm sharing the screen. This is.
You know, Dr. Lakshmi, I was asking Kavita also that today's session we should encourage all postgraduates to attend. It is so vital that they know more about tubectomy. So I'm trying to post it in everywhere in the postgraduate forum.
Madam, am I audible? Hello.
You're audible, but your
Screen?
screen is not seen. No. Share the screen, please.
Yeah, I shared. 1 minute, ma'am. This is.
Is your slide open on the desktop?
Yeah, madam. It is open here.
Open. Then,
Okay, nothing.
because I have stopped sharing, so it should come for you. The green icon you have pressed. Press the green icon.
Wait.
Down.
Actually, I pressed and then only I opened.
Then you must be seeing one window which is showing your slide. That window you have to press and press share.
Our screen share out of it.
Can somebody help you in the hospital?
Wait, madam. Actually, no. Screen share ಆಗ್ತಾ ಇಲ್ಲ ಪ್ರಶಾಂತ್. I need to come out of it first.
Hello, Jignesh. Just help the madam.
Yes, ma'am.
Anjali, Prabha ma'am को help कर.
Agidiyamma? Is it done?
No, madam. 1 minute. This is.
It's a regular Zoom platform. Should
Yeah,
not be
I
on.
know. This is actually I have done the screen share button on. Okay.
You will
But-
see a window with different displays, no? One of them will
Yeah,
be
yeah.
having your open slide
Yeah, I have,
that you click and click share.
I have,
प्रभा मैम
yeah.
आप विंडोज यूज कर रहे हैं या फिर मैक?
ये वन मिनट ये शेयर करूं क्या मैं? यहाँ पे ऐसा दिख रहा है शेयर शेयर
वहाँ
This-
पे शेयर स्क्रीन का ऑप्शन आया होगा नीचे
हाँ,
बॉटम में,
yes.
तो आप वहाँ पे
हाँ, yeah.
हाँ.
Okay, I know. Suddenly this software that has been changed of my laptops. Previously it was Windows and something else.
ओके मैम, अभी आपकी स्लाइड विजिबल है, यू कैन
Yeah, yeah.
कंटिन्यू.
Wait. Yeah. Okay. Am I audible, ma'am? Hello. Hello.
Yes, ma'am, you are
Yes, madam.
audible.
Yes.
Yes. Okay. A very good afternoon and warm wishes from the city Gadar and from my side. I'm extremely thankful to Dr. Shobha Gudi madam for giving me this opportunity to present such a prestigious platform about the laparoscopic sterilization in difficult cases. And I'm really very happy to be a part of this program along with a chairperson of ICOG, Dr. Lakshmi Srikhande madam. In fact, I heard about her so much thing, but for the first time, I think I'm being a part of her programs. Namaskara madam. And I this Sankalpa webinar for family planning is doing many activities, and Shobha Gudi madam from our side, from our Karnataka, is so much active in that, and she's really doing so much of things about the family planning services. So today's my talk as laparoscopic sterilization in difficult cases. Why we are just talking about laparoscopic sterilization? Because gone those days when we are doing the open tubectomies or the this peripartum tubectomies, there are many complications were there. But nowadays we are seeing most of the even camps and all about the laparoscopic tubectomy itself. So anybody is there? I'm seeing this slide.
Yeah, we can see your slide.
Yeah,
You
yeah,
can
madam.
go ahead. Yeah.
Okay. No, I cannot read my slide itself. This is showing some bar up the screen. Okay. So there are various types of tubal ligation by laparoscopy. We can usually apply clips or bands or electrocutions. These all things are just a method to do the tubectomy. But what about this is, if the case is simple, it is only 1 or 2 deliveries, normal deliveries, no any previous medical or surgical histories, then fine. But if we are having for what about the cases which are having a medically high risk, like heart disease patients, or those who are very much obese, previous multiple exploratory laparotomies or previous LSAs cases. For those, especially this talk is for such cases. While doing tubectomy, what all difficulties we will face is the main issue. So why I'm talking about this electrocoagulation? Because as a surgeon, we all know about the alternative methods of doing the tubal ligation, not only about this silastic band technique. Because when we are dealing with difficult cases, we should know what all other techniques are useful. We cannot just stick on to the one technique. So we can use an electrocoagulation also, usually bipolar we use. Clips are not much famous in India. So in bipolar coagulation is characterized by discrete or localized burn at two sides, and the interval part of the tube has been cut. And we all know we should take out the around 2 to 6 centimeter area of the tube at by both the sides. We should coagulate around keeping the 25 to 30 degree 25 to 30 volt current, and then excise the interval part of the tube. But and we should buy this technique mostly in cases of adhesions. I use this technique, and we all should be well versed about this technique also. It is only disadvantage of this is reversibility criteria is poor in case of coagulatory electrophoresis has been used, because there is a lot much of lateral spread and more than a visible area get damaged in this coagulation technique. So if you see the categories of 1 minute, actually this.
We can see it very well, Prabha.
No, actually no. This something mute, stop video, security, these all are coming in my middle of the presentation. I don't know how to take out them by the side.
Okay.
Shows
probably somebody should help you there.
Yeah.
Some displays are coming, right?
Yeah. This, even though AP ಇವella ಇದು ಡಿಸ್ಪ್ಲೇ ಅದೆಲ್ಲ ಬೇರೆ ಕಡೆ ಹೋಗುತ್ತೆ.
Yeah, you can keep on speaking on the ACDS actually.
Yes, madam. Yes, madam.
Yeah. Yeah.
So there is, as per the ACDS categories, we should do a triaging of the patients, and which patients, and while doing the tubectomy of such kind of patients, we should know that this is either category A or C or D or S. What do you mean by A? A is there is absolutely no medical reasons to deny the tubectomy, and there is no any other high structure. C is the patients, the method is normally provided in a routine setting, but with the extra preparation and precautions. Okay. And D is use of methods should be delayed until the condition is evaluated and not corrected. Then D is use of methods should be delayed until the condition is evaluated and corrected, especially in cases of emergencies, where when we are dealing with them, suppose a cesarean section and PPH is going on and patient has already, we are going to consent for tubectomy. For such cases, we have to delay our decision of doing tubectomy. And the special situation like category S is the procedure should be undertaken in a sitting with an experienced surgeon and the staff. Equipment needed to provide a general anesthesia facility should be there. That means these kind of cases should be done in a well-equipped hospitals with all alternative methods of managing a patient's medical support and the ICU supports, everything, if needed, should be there. Then, till then, such kind of patients, they get the special care and get arranged for such hospitals. They should be advised for having alternative contraceptive methods. So, what are the cautions? Means what are type of C category patients are like obesity, extremely overweight, and elective abdominal surgery at the time of sterilization if there has been posted, but these C group patients should not be taken in emergencies. Then delay, just now I told that should delay the procedure undergoing abdominal surgery, like when we are doing abdominal surgery for an emergencies, or infected patient, we were planned for tubectomy, and if we found a lot of infection, active ongoing infection is going on, for such cases you have to manage that thing first. That's why you should delay your tubectomy. or major surgery with prolonged immobilization is required. With such kind of surgeries, we should not combine our surgery tubectomy. Then what is special precautions is preparation is needed for such patients. We should be very well. Just now, Srinivas sir was telling that because of recurrent PID and even adolescent patients are getting the infections because of change in lifestyle and all. Such kind of history of recurrent PIDs, pelvic tuberculosis, or previous laparotomy patients, we should be very well alert and should take a special preparation before going for tubectomy of such patients. Slide is not moving. The slide is not okay.
Yeah.
Then operative steps. I just put few important operative steps in case of difficult cases. Everybody knows the normal port placements by somebody puts with a Veress needle, somebody do a direct TOCA technique, because usually most of the tubectomy patients are multigravida. So it is very easy to get approach into the abdominal cavity. But in cases of difficult cases, very obese patients, previous laparotomy, previous means as I discussed about the infections and PID cases, it is better to, it's very important to select the site of primary port placements. Usually we use intra or supraumbilical port, but open Hassan's technique I prefer in cases of previous adhesions.
Is there a connectivity issue? Hello? Prabha? Hello?
Looks
Hello?
like she's disconnected.
ಹೌದು ಫೋನ್ ಮಾಡ್ತೀನಿ ಅವ್ರಿಗೆ. Patel sir, you are there, sir. You are ready. So
Yes, I am
yes,
ready.
Yes, sir. I'll just check with her. She's having difficulty. We can complete yours and then go back to her because she's having difficulty. Yeah. Yeah, Prabha, you were disconnected. You're muted now. You're muted.
No,
No.
Anybody else is managing my screen?
No.
Nothing.
Do you want to share the PPT, Prabha?
Yeah, it would have been better, ma'am.
Can I request you to, Prabha?
Yes, ma'am.
Can I request you to
ma'am.
complete your presentation after Dr. Patel? Will it be okay for you? If you can
No problem. Means there is much of disturbance, I think.
Yeah, that is why you share the PPT and
anybody
you
else is managing my screen? Or
No, that cannot happen. In Zoom, one person only will manage. So you do one thing, you send it back to the place where the invite came from and you send it to me also.
How? Actually, I need
No, you log out and send. By the time we will bring in Dr. Patel and finish his talk. You please join back as soon as possible.
Yes, ma'am. Log out and send by?
No, you can keep logged in and you can, open another portal and send a mail. Not a problem. It is possible.
Mail.
Or you log out and send, whatever is convenient. Meanwhile,
Okay.
Dr. Patel sir will speak because I think webinar time should be utilized to the best. Huh?
Now you can see.
Please come back. We are very eager to hear the full talk.
Okay.
It was going very well actually. Dr. Srinivas, I am sharing the PPT of
Yes,
Patel
ma'am.
sir and kindly introduce him. Sir does not need introduction. Actually, he has become so
Absolutely.
well known. But any which way, we have to do our duty. He has great webinar. So here goes. Yeah, please introduce him.
Yeah. As Shobha Madam rightly said, the Patel sir doesn't require any kind of introduction, but as an obligation or as a formality, we try to put a couple of sentences known about him, at least for a few people, if postgraduates have joined, if they do not know. He is a consultant obstetrician gynecologist and medico-legal counselor. He was the vice president of FOGSI in 2018 and organizing secretary of ICOG 2017. He was the chairperson of Ethics and Medical Legal Committee FOGSI 2011 and 13. Honorary Secretary of State Organization of Gynecologist and Obstetrician Gujarat. Organizing chairperson MMCon 2018. I think he has got quite a few membership of various associations and national president of National Medicos Organization. I think he is the most wanted person by everybody. Anytime any problem happens to a doctor, the first name that comes to our mind is Patel, sir. Yeah, he is the honorary surgeon, Indian Red Cross, I Bank, collected more than 1,000 eye pairs. Congratulations, sir. President, Lions Club, Ghatlodiya, Ahmedabad, convener, Ahmedabad Zilla, BJP Doctor Cell, Joint Secretary, Umia Parivar, Ghatlodiya, Ahmedabad. Nowhere he has mentioned that he is available for consultation for medical legal problems. Sir, I want to add that. For the audience, I think if they have any issues with sterilization or any other OB or gynae problem, the first person I think we should contact is you. Over to you, sir.
So please
Thank
share
you.
your screen.
Yes, yes. Thank you, Srinivas, for kind words. Is my screen seen?
Yes, it is seen.
Yes, and I am audible.
Yes, sir.
So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank ICOG Chair Dr. Lakshmi and Dr. Shobha Gudi, in charge of this webinar series from ICOG for family planning issue. So thank you for the same. Legal issues in female sterilization operation. Usually I start any of my medical legal talk with this question: is it worth discussing? Yes, and if it is yes, then why? Why there is so much fear about this important surgery? Female sterilization operation is very important surgery and very common surgery in our practice. But many times, so many of friends are little conscious because many times government's guideline, many times illogical at times. Most practitioners do not know them well. And being a national program, tracheotomy death is an issue discussed in parliament and doctors becomes a soft target and failure cases make a breaking news for media. So these are some issues we are much conscious about the case. Let us see few of the cases which are decided in different courts related to female sterilization operation. Lower segment cesarean section with female sterilization operation. In this particular case, during tracheotomy was done, and allegation was it was done without consent. Case was filed in this. Defense on part of doctor was during operation found next pregnancy to be dangerous, and patient was asked, but as such surgery was done under general anesthesia, so consent was not possible. And in this particular case was allowed in favor of patient because it was without consent. The argument that next pregnancy would be dangerous, it was not immediate necessary. Whenever it is immediate necessary to save life of patient, you can extend scope of consent given or even without consent. But in this particular case, if at all he would have not done female sterilization operation, patient was not going to become pregnant very next day. So it was not an emergency. So in court of law, argument was not considered and case was allowed in favor of patient against doctor. So number one reason for litigation is sterilization operation without consent. Let us see one more case. Two girl children. It is very famous case. Recently judgment came and it was published in newspaper also. Two girl children, tubal ligation done. After 5 years, she delivered female baby and it was her third child. So family feared that assistance provided under government welfare scheme for girl children would be denied to it's because of third child. And they approached state health department with plea of rupees 10 lakhs compensation for raising the child. So authority rejected the plea and instead offered only 30,000 rupees as a compensation. She approached High Court and case was decided in favor of patient, and judgment was very surprisingly. Court allowed compensation of rupees 3 lakhs to mother and rupees 1.2 lakhs per year, that is 10,000 per month, to baby till she completes her graduation or attains age of 21 years. So it is very strange judgment as far as failure of contraception is concerned, and it was published in newspaper also. So in this particular case, comments were tubal ligation failure is known. Failure doesn't amount to negligence per se. 100% success cannot be expected or guaranteed. Patient may consider MTP in case of failure. Tubal ligation without consent during other surgery may amount to negligence. If failure is because of carelessness during tubal ligation, doctor may be held liable. If operation is performed under family planning program and free of charge for all the patient, then patient doesn't become consumer and cannot file complaint in consumer court. So as far as this particular case is concerned, there are so many grounds, and this is good case to prefer appeal in Supreme Court. Let us see one more case. In this case also, tubectomy was done, tubectomy failed, case was filed, compensation demanded, defense on part of doctor was operated as per standard norms, and inference held by the court, failure rate admitted to be 0.4%, which it was expected, accepted by court also, failure rate. No expert evidence that operation not carried out as it should have been done, and case was dismissed in favor of doctor. So we saw two cases, failure of contraception, failure of sterilization operation. In first case, case was decided against doctor, and in this case was decided in favor of doctor. There are so many cases. I can quote a few of the cases here. In all these cases, judgment came in favor of doctor. So if we put our case in court of law in any kind of litigation in failure of sterilization operation, there are all chances to win the case. But how you put case before honorable court is very much important. So in all these four cases, judgment was in favor of doctor. So second reason for litigation is failure of operation. Let us see one more case. Mother of 7 children operated on right fallopian tube only. So it is a very interesting case. During her speech, Dr. Lakshmi mentioned one interesting case that she couldn't find one tube, and she counseled post-operatively to the patient and patient party that she couldn't operate on one side tube. So it was good as far as post-operative counseling is concerned in this type of situation. But in this particular case, he could operate only right tube, but assured complete and successful sterilization. It was very big mistake on part of operating surgeon. Certificate of that effect was also issued. Patient conceived and gave birth afterwards to a female child. Case was filed. Compensation was demanded. Defense on part of doctor was contended that no negligence, no vicarious liability, no entitled for damages, as she put thumb impression on case paper that in case of failure will not claim any damages. So this type of writing on part of patient doesn't stand in court of law in many times. So we should be very careful in this type of condition. So in this particular case, inference held by the court was family planning operation is important national program. Mass awakening is created. Doctor as well as state must be held responsible in damages if operation fails on account of his negligence, resulted in birth of another child in family, creating additional economical burden, but didn't consider consent form. In this particular case, also observed that left tube was not ligated and proved from the record and statement, and in spite of this, certificate was issued, and certificate was issued of total complete operation. It was not taken into granted by court, and court passed stricture also. So statutory liability to maintain children is no bar in claiming damages on account of tort on medical negligence. So case was dismissed against doctor and compensation was passed to the patient because as left tube couldn't be operated, then also certificate of completion of operation was issued on part of treating doctor. Let us see one more case. In this particular case, owner of nursing home called surgeon for tubal ligation. During operation, patient died. Case was filed. Compensation demanded, and defense on part of surgeon was surgeon contended that he never operated this very patient. It was very poor defense on part of a treating surgeon because record was already there, and from record it could be proved that the same surgeon operated this very patient. So record was contradictory and inference held by the court. Only surgeon was held liable in this particular case, and only fee promise would be enough to make patient a consumer. If patient pays for operation or any treatment, or patient promises to pay, patient becomes a consumer in this type of situation. So in this case, compensation was allowed to the relative of the patient. So one more reason is death related to female sterilization operation is reason for litigation, and any complication related to female sterilization operation is one more area as far as litigation is concerned. So if you were called to a nursing home owned by BMS or any other person to perform sterilization operation and there is a death, which call for inquiry, the owner or operating surgeon? Many times both are called for inquiry. So whenever you are visiting surgeon to any other hospital, you should be very careful as far as your role as a operating surgeon is concerned. And there could no exclude. If you are visiting surgeon, I didn't know hemoglobin, I didn't know that oxygen cylinder was empty, I didn't know she was a cardiac case, I was not informed about post-operative condition, because wherever you operate in other hospital, other than your own hospital, you are under obligation to take or to manage post-operative care. Either you should have managed the post-operative care, or you will have to manage care to be taken by equally competent person. If you can delegate any other person to take care, it's fine. But you cannot leave it to mercy of patient, and you are under obligation to manage post-operative care also whenever you have operated any other hospital also. Let us see for some situation. Can we perform laparoscopic tubal ligation along with medical termination of pregnancy or spontaneous abortion? Because many a times tubal ligation can be performed along with termination of pregnancy or spontaneous abortion, because old guidelines on part of government doesn't stand nowadays. But laparoscopic tubal ligation should not be done concurrently with second trimester abortion, because it carries injury to gravid uterus, and immediate postpartum period laparoscopic approach should be avoided. It was guideline on part of government. Are there any absolute contraindication as far as female sterilization operation is concerned? As such, there is no absolute contraindication, but there could be some relative contraindication, and we should consider at the time of selecting the patient and deciding to go for sterilization operation also. As far as psychiatric disorder is concerned, psychiatrist certificate and legal guidance consent is very much needed, because many a times mentally challenged patient is brought to us by their relative or many times mother, that she is mentally challenged and we do not want her to be pregnant. So please go for female sterilization operation. Many a time they may demand for hysterectomy also, merely on the ground that she is unable to take her personal hygiene care. But in this type of situation, certificate from psychiatrist is very much needed, and many a times in few of the cases, court has denied permission to go for surgery in this type of situation. One more area, allergy to local anesthesia. So you can use alternative methods, but it could not be the absolute contraindication for female sterilization operation. Gross obesity. So in this type of, if you are competent enough, you can operate under general anesthesia, but gross obesity also is not absolute contraindication, but it is relative contraindication. Physical illness making surgery risky, you can take decision as per the case may be. Some postpartum condition like puerperal fever, prone for more than 24 hours, pre-eclampsia or eclampsia, APH or PPH with hemoglobin less than 8 gram. So these are some conditions having relative contraindication as far as female sterilization operation is concerned. Trauma to genital tract and history of postpartum psychosis. So these are the conditions we should be very careful at the time of selecting patient to go for sterilization operation. Which are the mandatory investigation before doing tubal ligation? There are guidelines on part of government. Hemoglobin should be at least more than 8 gram. Urine sugar and albumin should be done, and diabetes mellitus should be ruled out. Medical officer and operating surgeon has to sign fitness certificate. It is prescribed certificate on part of government that patient is fit for surgery as far as female sterilization operation is concerned. What anesthesia is recommended? So previously it was guideline that preferably it should be done in local anesthesia, and spinal anesthesia or epidural anesthesia was not mentioned. Skin testing not mandatory. IV line recommended. Lignocaine without adrenaline should be used, and maximum dose recommended was 3 milligram per kg body weight. But as far as general anesthesia consideration is concerned, there are some indications, and general anesthesia can also be considered in case of non-cooperative patient, in case of excessive obesity, in case of history of allergy to local anesthetic agents. You can prefer general anesthesia also. But in consent, it should be mentioned that it was discussed with patient, and patient opted option to go for general anesthesia. So as far as female sterilization operations are concerned, there are some reasons for litigation. Why in this very common and simple surgery litigations occurs? We saw that lack of consent, death of patient, complication related to surgery and failure of operation we saw. But some other areas are also, because surgery performed on a healthy individual. Because usually whenever we go for female sterilization operation, they are comparatively young patient as an elective procedure. It is not any pathological condition except very few conditions. Not for treatment prescribed by doctor for medical condition except very few conditions. People cannot accept any adverse outcome because patient comes on foot, and if at all something goes wrong, then it is not acceptable to patient, party or family member. So what to do and how to prevent not to end up into litigation? There is a selection criteria, and as per protocol laid down by national government based on WHO criteria. Can we perform tubal ligation on a woman of any age? This is very important question. So guideline is very clear. We can operate between 22 to 49 years of age as far as female sterilization operation is concerned. Can we operate unmarried patient as far as sterilization operation is concerned? Client should be married, including ever married. So it is very clear. Married but not having any living issue, can we operate? So she should have at least one child more than 1 year of age, unless sterilization is medically indicated. If it is medically indicated, then this option is waived. Client or her partner must not have undergone sterilization operation in past, and in case of failure, then we can go for sterilization again, but otherwise it should not be done. Client must be in a sound state of mind so as to understand the full implications of sterilization operation. It is also very much clear. And mentally ill client must be certified by psychiatrist, I mentioned prior also. And the final selection of case should be based on case selection criteria guided by medical eligibility. So protocols are laid down by national government based on WHO criteria. As far as consent of patient is concerned, it should be informed consent. Are your patient properly informed? So proper counseling is very much important. We should explain all the available methods of family planning to the patient when patient is for female sterilization operation. We should offer her temporary methods also and permanent methods, and we should explain everything related to permanent methods. For all practical purpose, this operation is permanent one, informed decision, and it should be voluntarily taken. Language which patient can understand, we should explain everything in language. Side effects and potential complications, we should explain to the patient. Features of sterilization procedure must be explained to the client, and it is surgical procedure that has a possibility of complication, including failure and ectopic pregnancy requiring further management in future. We should counsel that also. It doesn't affect sexual pleasure, ability, or performance. It will not affect client's strength or her ability to perform normal day-to-day function, and sterilization operation doesn't protect against any RTI, STI, HIV, or AIDS, and reversal of surgery is possible. But again, it is a major surgery and success cannot be guaranteed. So this type of counseling should be there as far as sterilization operation is concerned. And client must be encouraged to ask questions to clarify their doubts, if any. And it is very important to explain that client must be told that they have the option of deciding against the procedure at any time without being denied of their right to other reproductive health services. So if they are not ready to go for female sterilization, they cannot be deprived with any other reproductive health services. It should be very clear. Does consent of spouse required? So there are two options. One is yes, because as far as court's verdict is concerned, in one of the cases, it was inference held by the court, when you are going to put full stop on reproductive capacity of couple, husband should be taken into consideration and signature of husband should be taken. But at the same time, there are government circular in so many states that consent of spouse is not required. So if you have followed guideline on part of respective state government circular, then you are pardoned from any of the litigation merely on the ground that consent of husband was not taken. Sterilization operation with lower segment cesarean section, of course we can do, but many a time so many of our friends are afraid to do sterilization operation with cesarean section, because being national program, tubectomy death is an issue discussed in parliament, I mentioned prior also, and death cases making a breaking news for media. So our friends are worried to go for a sterilization operation, because if at all there is complication related to cesarean section or death related to cesarean section, the separate inquiry will be there if sterilization operation is done with lower segment cesarean section. So we should explain in a very simple language, no much medical jargon should be used, and no rosy picture about result, no tall claim about result, because in our sterilization operation services, we consider result like Aishwarya Rai, but it may turn like this anytime. So we should be very clear in explaining everything, because in eye of law, when you claim to be master, you are supposed to be master. And as far as consent is concerned, you have to simply visit FOGSI website, and on FOGSI website, uniform consents are available. We three medical legal counselor, Dr. Nikhil Datar from Mumbai, Dr. Dilip Walke from Pune, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consent. Say, for example, cesarean section, hysterectomy, abdominal, vaginal, endoscopy. And in those 30 consent, we have prepared consent for tubal ligation also. And we have taken base of this famous case of Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court in 2008 as far as consent is concerned. So we have prepared consent in two parts, and part one is information about surgery. Say, for example, name of procedure, abdominal tubal ligation. We have prepared in a very simple language, meaning what is the meaning of abdominal tubal ligation? We have mentioned in very simple language. Purpose or indication, why we are going to go for sterilization operation abdominally. Description of procedure, how this operation is done. Benefit of procedure. Alternative, if patient is not willing to go for abdominal tubal ligation, then which are the alternatives? We can offer them laparoscopic route, vaginal route, or we can offer other alternatives also. Consequences of refusal of procedure. Many times patient may go for refusal. Online substantial risk. We have mentioned everything, including failure and possibility of ectopic pregnancy in future, excessive bleeding or blood accumulation in very rare condition, possibility of infection, injury to surrounding structure during surgery, a complication of anesthesia. Every individual has a different way to cope up. We have mentioned that also. We have mentioned some very rare condition also. Inability to reach fallopian tube also we have mentioned. And as far as laparoscopic route of tubal ligation is concerned, same way with all subheadings we have prepared consent for that also. And part 2 of consent is undertaking. So whatever we have explained to the patient in part 1 in information, patient will go in undertaking in part 2, and at the end of consent, patient will sign or patient will give thumb impression if patient is illiterate. But in this condition, thumb impression should be attested by person who knows the patient and who is major and mentally sound. And 2 witnesses, one on part of patient and one on part of hospital, and signature of doctor is also very much needed in consent form. So protocols are laid again as far as operative technique and criteria for providers are concerned. So I do not go into detail what are the minimum qualification, who can operate female sterilization operation due to paucity of time, and which are the physical requirements is also very much mentioned in guideline. Required space, facility, equipments and supplies, essential drugs, everything is given. But as far as compensation part is concerned, it was 50 pages manual for family planning insurance scheme, and it was on part of government with ICIC Lombard, and there are some very important guidelines as far as compensation is concerned. If death occurs within 7 days, then compensation of rupees 2 lakhs. If death occurs after 7 days, that is 8 to 30 days, then 50,000. Failure of sterilization operation, 25,000. Cost of treatment for complication up to 60 days, that is 25,000. And in part second section, it is mentioned up to 2 lakhs per claim and maximum 4 cases per year. But for that, your hospital should be N panel and you should be N panel with the government list, and it is very clear. So proper communication, proper documentation is very much required. And when you counsel patient well and when you take signature on consent paper, it becomes a documentation of your communication. And whenever you offer all this record in court of law, it becomes a communication of your documentation, and it becomes a good defense in your favor whenever you are facing litigation related to sterilization operation. But records are always at your rescue. So keep them up to date. What was done, nothing was neglected, given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court, because doctor is bound to produce record whenever asked by the court, and if he doesn't, then adverse inference might be drawn, and it is very obvious. Good record is good defense, poor record is poor defense, and no record is no defense. And we doctors friends are very poor at record keeping. It is my experience during my medical legal practice. There is always a way, because this gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So there are so many provisions in law in our favor as far as any litigations related to female sterilization operations are concerned. But many times we do not know, so it's not useful. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. Because in spite of all these occupational and professional hazards, our journey to serve human and mankind is always on and on. And usually I complete my talk with this picture. If you want to sleep like this, take tender care of your patient. Good counseling with patient and patient family. Pray your Almighty God before going to sleep, and keep my visiting card below your पी लो. सत्य परेशान हो सकता है लेकिन पराजित नहीं. And this is law of leopard behind innocent gynecologist. And see the role of medical legal counselor, how he can be useful in any given situation. So please do not hesitate. Please have a phone call to medical legal advisor whenever you are in doubt. With regard, salute to all the society who have joined this webinar and organizers, and particularly Dr. Lakshmi Sikhande, ICOG chair, and Dr. Shobha Gudi, convener of this series. Thank you very much. Please do not assume. Please ask if any query, any question, if chairperson and time permits. Thank you very much.
Such a pleasure to listen to you, sir.
Thank you.
Very well highlighted, sir. On both those occasions, I was saved because I had documented on their
Yes.
case paper that I could not find the another fallopian tube, and that's why I have not ligated it.
Yes.
I had informed them. That is why I was saved. Because the second patient did become pregnant after 1 year in spite of those dense pelvic adhesions, she became pregnant.
So post-operative counseling is equally important.
Written.
Put on
Face this
PPI, you
type
see.
of and in
Put up
discharge
IUC.
card, in discharge summary, in discharge card,
Yes.
mention that you couldn't operate that very tube.
Yes.
And patient is instructed, if at all she misses the period, then she is advised to consult hospital immediately. And if at all she comes with pregnancy, you can offer option of medical termination of pregnancy also. And in spite of all this, even if patient opt to continue pregnancy, then it is up to patient.
That is why, sir, on this platform, I just want to advise all the freelancers, because once upon a time, I was also freelancing laparoscopic surgeon. The tubal sterilization failure, if it fails, you are legally responsible, not the person who called you for doing lap sterilization. So that is why it is your responsibility to put the discharge notes, the summary in your hands, and do talk to the patient. Because it so happened that in one case that the wound was not healing. In those times, 30 years back, sir, we used to do the port closure with the thread.
Yes.
So in routine things, they will not tell them ki who was the laparoscopic surgeon who obtained behind the curtain. But once complication occurs, they inform कि वो डॉक्टर लक्ष्मी शिखंडे ने आके ऑपरेट किया था, उसका हॉस्पिटल फला फला जगह है, तुम जाओ और ये जो स्टिच पक गया है ये जाके अब उन्हीं से निकालो, because she could not remove that thread. Freelancers, please be careful. If any complication occurs, you are responsible as an operating surgeon. I mean, I'm giving this advice in front of Dr. MC Patel, but because मैं वो सब भुगत चुकी हूँ.
You are very clear, and it is, but in this type of situation, many a time, patient may prefer to make party both of them, operating surgeon as well as hospital under whose roof patient was operated.
But sir, it is mainly the surgeon.
But as far as post-operative care is concerned, either it is to be taken by operating surgeon, or he will have to manage care to be taken by equally competent person.
Fully competent
And
person.
in this type of situation, when he is visiting operating surgeon, in his operative note, he will have to mention if he couldn't operate one tube or so. So with operative note, he will be saved. Otherwise, he will be put into trouble in this type of situation.
Yeah, that's what even Dr. Lakshmi said, that documentation saved her. Dr. Srinivas, there is one or two question in the chat box, and then we'll go across to Prabha to see if she can display. Yeah, one question, I think so.
I'm not able to see the questions.
Okay, I will do that for you. I think our Radhika has asked, what about empanelment of doctors? Is it compulsory for sterilization?
It is not for sterilization operation, but if you want to cover that operation as far as compensation part is concerned, then your hospital should be empaneled, and you should be empaneled with government.
Otherwise, there is no benefit.
No, otherwise, if you do not want to go for compensation, then you can very well operate sterilization operation in your private hospital also.
Yeah, but
basically
I think
the sterilization operations could be either in the private hospital or public hospitals, and public hospitals it is free of cost. So indemnity scheme applies only to places where the sterilization is provided at no cost. And if you want to make use of that indemnity scheme, what the sir just now said about 2 lakhs, 50,000, 30,000, 25,000 compensation for various categories like death or failure, if you want to make use of it through the government, your hospital should be empaneled, and the surgeon who operates should be empaneled. This is the rule.
Yes,
But
exactly.
they can charge, no, Srinivas? They can charge fees.
No, if they are charging, then
Hmm.
they don't come under the indemnity scheme at all.
So that's what. So private
Yes.
hospitals have to run
Private
at a cost.
hospitals,
So they
yes,
will have
when
to
they
charge the
empanel,
patient. Yeah.
yes, when they empanel, they should guarantee that they're not charging for the sterilization procedures. So the
For the
second issue I
surgery,
just wanted to raise was about laparoscopic surgery. One more guideline also has clearly said laparoscopic sterilization can be performed only by surgeons who are trained and certified in laparoscopic sterilization. So this is not a very clear sentence. If there is a practicing laparoscopic surgeon who is doing hysterectomies and various other laparoscopic surgeries, he will not have a separate certificate for laparoscopic sterilization. So is he covered under this or not is not very clearly given in the guidelines, but the guidelines very clearly say that they should have a laparoscopic sterilization certificate. So this is one more gray area, I think.
Just to make it a little clear, in few of the states, some hospital were empaneled with government, but in this particular hospital, as far as female sterilization operation is concerned, either abdominal or laparoscopy, patients were brought by government, health workers, and it was totally free of cost, and whatever amount was to be paid, it was paid by government to that very hospital. In few of the state, there was a agreement between this type of hospital. So in this type of situation, if at all there is a claim for compensation, then government will protect
Absolutely.
that surgeon.
Yes, sir. Yes.
FC Patel sir, just one question. क्योंकि consent form में ही लिखा होता है कि there is chances of failure 1%.
Agreed.
So once we take signature on that form, which clearly mentions that it does not guarantee you 100% thing. So why compensation? Means, are we not safe that patient has signed that there can be a failure of sterilization?
But it is very clear, consent is to allow you to operate, not to go for negligence. So even if you have mentioned that there is a accepted failure rate and it is accepted by law also, then also you will have to prove by your operative note that you had operated that very patient as per standard medical norms. And if you can prove that, then you are out of problem, even in case of failure also.
एक related question, do we need to send for histopath, the tube parts? Will that save the situation?
So it is a word used, abundant caution. So at abundant caution, you can send fallopian tube, but again, you will have to label both the bottles, left fallopian tube, right fallopian tube. Otherwise, again, there will be a problem because report should mention specimen number 1, it was left fallopian tube and it was found, confirmed by histopathological examination.
But see, in laparoscopic sterilization, Shobha, we don't have the sample to send because just put the
in
bag.
laparoscopy, we don't have, but in mini lab,
So,
in mini lab technique, we can.
So it is not compulsory to send, because in one of the cases, not it was case of female sterilization operation, but to send specimen for histopathological examination is a question of opinion, and it is not compulsory. One verdict was given in one of the cases in court.
That's great.
But it is always better if patient can afford, then you can send.
Yeah, but it will not go against the surgeon.
No, it cannot be the
law, if it is not said.
It cannot be the mere ground for litigation.
Though it is not happening nowadays, one more important aspect that should be considered by surgeons who are working in camps. One surgeon is not supposed to go for more than 15 cases per day. And the timing should be between 9 and 5. They should not prolong beyond 5
now the number is not more than 30 or 50% per day, no? 30.
No, it is 15 per surgeon between 9 and 5.
Per center per day is not more than 30 or something.
But in
that
past,
is, if there are 2 surgeons.
In past, this type of camp, I have also operated 30 and more than 30 as well as tubal ligation abdominally in a one camp per day. But now, of course, this much cases are also not there in camp now.
Yeah, absolutely.
So 15 is a good number to operate in a day.
Sir, we had a fantastic, interesting session by you. And I think we can just go on, but I think my mistake, I should have kept only for you the session. We have 3 more brilliant speakers. what to
Yes.
do. So we will take Dr. Prabha's remaining presentation very, very quickly.
Thank you very
Dr.
much.
Prabha. Yeah. Sir, thank you so much, sir.
Welcome.
And
Always
thank
welcome.
you, Srinivas. Please
Thank you,
stay,
madam.
Srinivas,
And
for Prabha. Please,
please permit me to leave, madam. I have an assignment.
Okay, Dr. Lakshmi has to permit. I'm no one to permit.
No, I
He is
request
the
Lakshmi,
boss.
Thank you so
madam.
much for
Because
sparing your valuable time, both MC Patel sir, Srinivas.
thank you very much, madam. Thank you.
Yeah. Prabha, looking forward to your. Yeah.
Yes.
Share, please.
Now,
Yeah, please.
yeah, I changed my modem of internet.
Yeah,
Shall
yeah.
I share this this thing?
Yeah, please share. Please share.
You want me to
We're
start?
running out of time because, yeah.
Yeah, yeah. So I don't know from where to start now.
Go ahead. Go ahead. You had finished
yeah.
video, right? Yeah.
Now,
You were on procedures. On the video you were. Next, please.
yeah, operative steps.
Yes, you
Right.
were here. You can
Yeah.
make it full screen.
Yeah, yeah, I'm making it now. So operative steps
Mm.
are mainly pertaining to the complicated cases. I always prefer to put the port, primary port by Hassan's technique. Usually this technique is more commonly used by the surgeons. I don't know why this is not popular in gynecologists, but in difficult cases, better to have a Hassan's technique, or in palmar space, if they are having a vertical midline incision and or supraumbilical incision is there. And better to, after opening the primary port place, you should use a blunt trocar to introduce and then put your scope. So these are the few images to show how people I use a Hassan's technique to find this blunt trocar. Okay. Then there is always, in case of difficult cases, better to use two side ports rather than like a routine single port to use a clip. Because we will expect a difficulty, so it is always better to use a two side ports for better maneuverability. And after, if you find any some sort of bleeding or transaction of tube, or you are finding little bleeding, you should give some saline wash and look for bleeding. And important thing is, after completion of your tubectomy, if you are using a 10 mm port, or some inadvertently because of any other problem, if you need to increase your port site more than 10 mm, it's mandatory to close with the rectus sheath with Vicryl or suture material, because to prevent the port site herniations. Okay, and we see, even though with lap tubectomy, we see many cases of umbilical hernia or periumbilical hernia post tubectomy. Prevent that, we should use this, close our port site with the. This is one of the difficult case where the uterus, just now this Srinivas sir was telling that he could not find the uterus in its normal position. Everything was plastered to the anterior-abdominal wall. Here also, the post-LSCS patient, previous to LSCS, the uterus was completely adherent to the anterior-abdominal wall, which is called as ventrofix uterus. If the procedure is only tubectomy, there is no need to separate everything or just do adhesiolysis. It is not a necessary thing. Just go surf the tube and then put the clamp or bands, and always prefer to put double band. I don't know, actually it is for my mental satisfaction. There is nothing, it has been proven that two bands are less failure chances or all. But I always put two bands at both the sides for better safety and to just exclude the chances of slippage of one band. Then this is also a very common scenario where you find the like a frozen pelvis all over the abdomen. You will find the mental adhesions, and we have to really negotiate our scope through all the directions to reach to the uterus. if you could easily manage by negotiation, then there is no need of going for release of these bands. Otherwise, we have to really create a, rather than creating window, better to release the bands and then go for side port and then do your procedure with more safety measures. Here, I could manage without taking out the adhesions, but you should be really very cautious. And more is in case of acutely retroverted uterus, it is very difficult to get. If you put a single port, like this case, I tried to manage with a single port, and it was a bulky retroverted uterus, and the tubes were, has gone into and stuck. Means not stuck. They tend to fall back. It is very difficult to hold with one band applicator, especially in cases of bulky and retroverted uterus. And in such cases, there are chances of, by mistake, application of the clip to the bands to the round ligament risk is also there. That's why, and that inadvertently leads to failure of tubectomy. So we should always be sure that you are applying the bands to the tube only. For that, tracing of the tube up to its fibril end is necessary. And see, because we have traced the tube up to the femoral end, we should find the femoral cyst here. If it is symptomatic too big, we can combine the procedures, and then on table you can take consent if it is really, but because all the tubectomies we won't do the ultrasonography, as I think Patel sir, this is not necessary to go prior to the laparoscopy, laparoscopic tubectomy. We should do a ultrasonography and all. So sometimes we will have accidental findings. If the patient is, it is really mandatory for them, for the benefit of patients, we can go ahead at the same time. Then one more issue is tubectomy in case of ectopic pregnancies. Usually post-tubectomy, ectopic chances are around 7 to 14% chances are there. So in such cases, when we go for, even though they are post-tubectomized, when we go for ectopic surgery, it is better to go for contralateral side to be removed for prevention of recurrence of ectopic. So this is a ectopic tube. Of course, we have to do a salpingectomy of this tube, but the contralateral tube, we should not re-ligate it. Better to have a complete salpingectomy for such patients. Then this is a dense uterine adhesions and plaster tubes in cases when you have put the scope and you are feeling that it is a FOGSI. When you feel and there are findings of tuberculosis, better to do a complete evaluation, look for the signs of PID, okay, and take the biopsy of the tubercles if they are there, and look for Hughes-Curtis syndrome, which will give a clue for our diagnosis of PID, and then confirm so that we can at least treat her by AKT post-surgical. In this case, it was very difficult to find the tube. So I really has to do a adhesiolysis from all the sides and then separate, then isolate the tube after doing adhesiolysis and then for tubal ligation. then what the complications we will expect in difficult cases? It's first and foremost thing is port entry. The first port is usually blind, so we have to take a proper precaution for port entry, and for that the HASIS technique is the best. We have heard the cases of primary procar entry, and that side only aorta has got injured and patient dies on table. These all things are also still we will we get such cases to hear. So it's the best thing to take little time and have a first safe port entry. Then second is uterus injury chances are there because of side port or because of adherent uteruses, unusual sites of pulled uterus and all. Then third, we call it as loosening of the bands is not a actually complication, might be well not applied to a proper locations or in hurry. Mostly it is common in cases or sometimes in camps. Then injury to the adjacent structures like bladder or the ports and the electrocutions are there. So we have to be very cautious. Then uterine perforation or uterine artery injury by manipulator are also there. For that, not to worry. We have to suture at the same site. Any complications, if we diagnose intraoperatively and correct it, it does not have so much issues rather than missing the complications. Then for prevention of complication, we should be well prepared for the case. We should, before that, we should have that criteria, which criteria patient is suitable, and then post according to the need of the patients. Then we should be well planned. Even though a tubectomy looks like a small case, I usually keep the all, as a usual trolley for the laparoscopic cases, how we go for major case, because we don't know at what point of time we need which instrument. So it should be a well-planned surgery, precautions to be taken in case of complicated cases and as per the need of the case. We should have a fixed protocol for everything. If suppose your bands doesn't work, you should be ready with next what should be ready. So better, we should not be just going a prefix mind that with this step only is to be suitable. And if it doesn't work, we should have a second thought always and be ready for the second method. Then case selection is very important for safety of the patient. So as I said, what are the indications for various methods of the tubectomy? It is, every surgeon who is doing tubectomy should be familiar with all kind of techniques of tubal sterilization, and it is not like that one technique is more superior than the other, but whichever is possible and suitable at that site, we can follow it. Then it is difficult, if not impossible, to learn these all techniques, and better to not to send group D patients or category D patients to the camps or into the even though they are government recognized camps, the personalized effect care will not happen. So these are things we have discussed, that two puncture approach is better, and complete trolley should have all kind of approaches when you are doing tubectomy. One more thing while doing tubectomy, whether it is open technique or laparoscopic technique or any other cauterization technique, you should keep in mind that tubal reversibility is nowadays might be needed for that patients. So while doing tubectomy, somebody does the fimbrectomy completely, especially in cases when they are open tubectomies, or we have seen the cases with absent fimbria. It has been done in a very lowly, distal to the tubes. It's always better to have a small segment of the tube to be destructed, but it should be effective tubectomy to prevent the. So this is one of the tubal reversibility clip just I added to show that how distal tube has been cut in this, and it was very difficult to do a tubal anastomosis in such cases. Then Therefore, to preserve the relatively high rate of reversibility and to destroy the least amount of tissue, the actually clips, hello, is it audible? The clip.
Yeah, it is audible. It is audible.
Yes, ma'am. The clip appears to be ideal because it destroys only 3 mm of tubal
Yeah,
tissue.
agreed. Correct.
And if you apply a follow-up ring, usually what ring we use, it destroys approximately 2.6 centimeter of fallopian tube and involves only small amount of its vascularity. It should be considered the next least destructive method. Electrocaution destroys the largest amount of tubal tissue, even more than it apparent
Prabha,
by
we
doing
can
the procedures. But this is, yeah, ma'am, it is very only 1 or 2 slides.
yeah.
This is more pronounced when unipolar current is employed rather than a bipolar current. So proper technique is also important to reduce the failure rates. Then complications and their management, we all should know what all complications, even intra and post operative. The pain, patients usually complain of pain because of the tubal ligation. That is because of the ischemia and neural ending damage, or maybe the electrocution. Sometimes somebody practices with local anesthetic injection before clamping the tube. Then wound infections, usually if it is done in a good OT with antiseptic precautions, we have never found any patient of even port infections or the peritonitis post tubectomy. But these kind of cases may also come to see if it has been done under, it has not done in under aseptic precautions. Then complications of in case of intraperitoneal bleeding, if it happens, usually because of the tear of the mesosalpinx, it happens. So we have to tackle that thing. Then uterine perforation because of manipulator, then you have to control with the sutures. Then organ injury as per, but it is always better to diagnose on the spot and right? Abnormal uterine bleeding is one of the post-tubal ligation syndrome is one thing, but it is not proved yet, and because of tubectomy, it's a DUB. Then hernia, as I just told, that we should prevent by suturing. And one more technique, usually that is a jet insertion technique, is one more technique to be learned to prevent the hernia formation, in which usually skin will be covered, the skin will get covered over the rectal sheath insertion site. Then ectopic pregnancy rates, usually the CREST study demonstrate around 10 years cumulative probability of ectopic pregnancy of 7.3 per 1,001 for all methods combined. But usually it is because of the uteroperitoneal fissulas and more common with bipolar cauteries. So this is a rate of ectopic with the different methods. So to conclude, laparoscopic sterilization has become the most popular method of internal female sterilization. This procedure has an advantage of providing visual survey of upper abdomen, entire pelvic cavity, as well as much of the superficial bowel contents. Then it is sophisticated procedure with an array of highly technical and in some cases expensive instruments is needed, but it is have a cosmetic value also and has an early recovery. So we should use this technique and should delay the procedures when we are undergoing abdominal surgery for any other emergency cases, or it is an infected case, better not to do at that time. Then complications can be kept to a minimum if appropriate techniques are used and if the procedure is performed in an appropriate setting with the skilled providers. Thank you, one and all.
Thank you so much, Prabha. You can stop sharing now.
Yes, ma'am.
I think I think very well
Pause
brought
share.
out. Yeah.
Stop share.
Stop share. Yeah.
Yes,
Very
ma'am.
well brought out, and particularly the difficult scenarios. Okay. I think I shall move ahead now and introduce the chairpersons for the next session very, very quickly. Is Dr. Mrinalini Mani there? Has she joined? Anybody? Nilima? Hello? Nilima, has Dr. Mrinalini Mani joined? Not able to see her. Hello, Mrinalini, are you there? Well, she is one of the chairpersons, HOD of Guru Govind Singh Government Hospital, New Delhi. And I particularly, compliment her for being a very active Sankalp champion for our Sankalp Group for Family Welfare Committee in the past 3 years. Thank you, Mrinalini, for everything. I hope that you will be able to join because so far I could not see you. The next chairperson is another good friend of mine from Vijayawada, Dr. Sushila Pinnameneni. She is consultant OB-GYN, Datta Super Speciality Hospital, Vijayawada, and Samata Multi-Speciality Hospital, Mangalgiri. She is the president of Vijayawada OB Society at present, 22-23, and the secretary of the Vijayawada Menopause Society, a member of the PAC committee of FOGSI, and she has actually been very active in several committees of FOGSI. She has also delivered the FOGSI ICOG CL Javeri Symposium and has been a Dhira and RAC master trainer. She has been a very popular speaker at several conferences and was also has also a very fantastic hobby of photography and won the first prize for best photography of indoor and outdoor plants. So welcome, Sushila. And I hope you will quickly, introduce our first speaker of the session, Dr. Radhika. All over to you.
Yeah. Thank you, Dr. Shobha and Dr. Lakshmi for giving me the opportunity. And I'll quickly introduce Dr. Radhika. She's an assistant professor, Bangalore Medical College and Research Institute for the last 13 years. She's postgraduated from the Mysore Medical College, and she has been the senior resident in JIPMA Pondicherry. And to her credit, there are 3 national publications and 2 international publications. And she's been master trainer for PPIUCD and DMPA. And her field of interest is the teaching, laparoscopy, and high-risk pregnancy. Over to you, Radhika, to talk about the no-touch technique of IUCD.
Thank you, ma'am. Good evening, respected teachers and respected chairpersons. And I'll be sharing the screen. I'll be showing the video of no-touch technique. Are you able to see my video? Is it visible?
Yeah, it is visible.
Yes, ma'am. Yes, ma'am. So, but audio may not be visible, so I'll be talking on behalf of the video. This is a video recommended by NHM Government of India. So this is basically regarding no-touch technique of IUCD or copper T insertion. Okay, so we already know there are 2 types of copper IUCD which are available. One is actually a T-shaped device, which is copper T 380A, and there's one more which is a multi-load copper. So this is a copper IUCD. So no-touch technique of loading and insertion is basically applicable for copper T 380A, not for multi-load. Okay, so no-touch technique is basically recommended so that you are able to load the IUCD. Copper T 380A, you are able to load inside the packet itself without touching it even with a gloved hands. Okay, so the purpose of this is to reduce the chances of PID, pelvic inflammatory disease, which is most of the time happens during the time of insertion, and also to reduce the chances of perforation by doing a withdrawal technique. So no-touch technique and withdrawal technique are the techniques which are recommended by Government of India. But however, both these methods are applicable actually for the copper 380A device, or the T-shaped device, not the multi-load device. So you just check the instruments, counsel the woman the no-touch technique of insertion, and start doing the insertion technique. So initially, we usually measure the uterocervical length. So this is how we are going to measure the uterocervical length. So after painting, breaking, and measuring the uterocervical length, then you start loading the copper IUCD for the no-touch technique. Because copper IUCD has a memory of 5 minutes, it should not be loaded and kept prior to the examination. So do the examination and rule out any genital infections, measure the uterocervical length, then you start loading the copper IUCD. So this is for the measurement of the uterocervical length.
Yeah, Radhika, you were frozen at that time. Yeah.
Yeah. This is the copper IUCD packet. So before starting, I'll just tell you what are the parts of the copper IUCD packet. Okay. Yes. So this is the copper IUCD proper. We have a transparent tube. Okay. So this is called as inserted tube. And there's a blue one is called as blue gauge for fixing the uterocervical length. Again, fixing the uterocervical length is done when it is inside the packet itself, not touching with the gloved hands also. Then you have a white rod that is called as plunger. Okay. So white plunger, inserted tube is there, and you have a blue gauge, copper IUCD proper, copper T device. So this card in the itself to know how to fix the uterocervical. Okay. So the first step, what we have to do is check whether the packet is intact, whether the packet is sterile or not. That should be checked. Check the expiry of the copper device. Open the packet away from the copper IUCD device. So 1/3 of the copper IUCD device should be open. Put the plunger tube into the inserted tube. So plunger rod should be inserted into the inserted tube. Touches the tip of the IUCD. After that, the whole system, the inserted tube, plunger rod, everything is brought to the middle of the packet so that you have space for doing the no-touch technique of loading. Then push the measuring part back so that you have a firm surface for no-touch loading. So we should fix the copper IUCD device using the thumb and the index finger. Don't try to pinch the device. Don't try to fold it on the packet because package gets broken and the sterility will be impaired. So instead of that, you have to give the pressure from the right hand through the inserted tube. So push the inserted tube forward so that they automatically start bending. Then you pinch them. So initially, it should not be the pressure directly on the horizontal arms of the IUCD. So you just stabilize the horizontal arms with the thumb and the index finger. Give forward pressure on the inserted tube. So this forward pressure on the inserted tube is important. After that, when they're half bent, then you should start pinching them. Okay. So withdraw the inserted tube, pinch both the horizontal arms. Then push back the inserted tube so that these horizontal arms are inside the inserted tube. So this is how we load without touching the IUCD proper when it is inside the packet itself. So next thing is to fix the uterocervical length. For fixing the uterocervical length, you should not move the blue gauge. Okay. So if the uterocervical length is 7 centimeter, get the gauge to the 7 centimeter, move the whole system to fix the uterocervical length. Okay. So if you directly try to move the gauge, it is tight and again package will be the broken. Okay. So sterility will get impaired. Okay. So get the upper border of the blue gauge to the required uterocervical length on the measuring part. If it is 8 centimeter, this should come here 8 centimeter. If it is 7 centimeter, the upper border of the gauge should come at 7 centimeter. Then you move the whole system. Release the gauge, move the whole system so that the tip of the IUCD comes at the zero. Okay, so this is how you fix the uterocervical length. Now it is ready for insertion. So remove the whole of the packet. Insert it to, and then you start doing the insertion technique. So within 5 minutes, it should be inserted because copper IUCD has a memory. So once you insert without touching the vaginal walls, this should be inserted into the external os of the cervix and then it is advanced. So once the copper IUCD enters until the blue gauge sits on the external os.
I think we lost the video. Radhika's internet was a little unstable.
Yeah.
I'll call her. Meanwhile, maybe you could go ahead with Dr. Kavita's introduction.
Yeah.
I will just share because I think we are running out of time.
Time. Yes. Yeah.
Yes,
Doctor.
yes, because I think we will tell Radhika to come back later when we have time. Yeah, go ahead with Dr. Kavita.
Ma'am, you're able to hear now?
Yeah, I am able to hear. I'll stop sharing. You had gone away, Radhika.
Huh.
You finished that? That video is over?
Okay, ma'am. That no touch technique of loading was completely done.
Insertion? You want to share again? Anything
So
else?
insertion is done by withdrawal technique.
You want to share
Stabilize
again,
the,
Radhika? You will have
plunger
to be
with one
quick,
hand.
beta.
Huh.
You have not shared.
Stabilize
We are
the
not-
plunger with one hand and withdraw the inserted tube.
Radhika, we are not able to see your screen. You have not shared. You had gone out actually. Yeah. You have to be
Yes,
very
ma'am.
sharp about this.
So we are going to insert into the uterine cavity.
Yeah.
Then take the inserted tube and cut the thread around 2.5 to 3 centimeter away from the cervix. Don't be held with the artery forceps. So no touch technique is actually not applicable for the
The video
multi-load
is
device.
slower than your talk. It's coming slower. Okay.
So multi-load, we don't have no touch technique of loading. It is only fixing the uterocervical length. Then it is directly inserted because they are malleable
Is
hand.
it only me, Sushila, or you are also not
Yeah,
seeing?
yeah, it's the same. It's the same.
It is
Oh,
not
okay.
moving.
I think there were some network issues, ma'am.
Yeah.
You
Because
go
of the
forward with the
networking.
next video. This is not happening. Go to the next video, please. You have any other video, Radhika?
Ma'am, PPIU series, should I share?
That's all. You finish with that this time. Okay.
Just a minute, ma'am.
Yeah, because LNG, we will leave it out. We just show PPIUCD, then we'll go across to Kavita because we are quite late this time. We could not finish in time today. Yeah.
So postpartum IUCD insertion requires a special forceps called as Kelly's forceps. So after painting and draping, if you are doing it immediately for delivery, you have already done the painting, draping for the delivery. Okay. So after cervix is cleaned with it, then open the IUCD packet, take out the plunger, insert the tube, everything except the copper IUCD. Only copper IUCD kept inside the packet. Then insert the special Kelly's forceps. So this is the special Kelly's forceps. So it is inserted into the copper IUCD pack, and the copper IUCD is held in between the junction of the horizontal and the vertical arm. Okay. So that is, then without touching any of the vaginal walls, insert into the cervical canal. So you start advancing the IUCD after inserting into the external nose. So once you feel the resistance, stop it, stop the
Radhika?
procedure, and the
Radhika?
left hand will be on the patient's abdomen.
Radhika, can you hear me?
Ma'am?
We are now seeing
Ma'am,
the
video is
video. We are now seeing the video where the copper T is going into the cervix. From there, you tell your. Yeah.
Okay. Yes, ma'am.
Yeah, go
So
ahead.
once you feel resistance, the abdominal hand, keep
Yes.
the left hand on the abdomen,
Yeah.
and push the uterus upwards and backwards so that
Yes.
you straighten out the uterocervical axis. Okay.
Yes.
So the Kelly's forceps is advanced later. So initially, once you feel the resistance, stop it, put your right hand on the abdomen, straighten out the uterocervical axis by pushing the uterus upwards and backwards. Then
Yes.
advance the Kelly's forceps till you feel the resistance or till you reach the fundus. So how do we know that we are completely inside the fundus? We are reaching up till the fundus. One is whole of the instrument has gone inside. Only the rings are seen outside. And with the abdominal hand, you will be able to feel the tip of the Kelly's forceps on the uterine fundus. So this is the one, the whole of the instrument is gone inside. So open the blades of the Kelly's to drop the IUCD in the center. keeping the forceps blade open, come to the lateral part of the uterine wall. So you should keep the blades open. You should never close it when you're taking it out. So once you have dropped the IUCD, keep the blades open and sweep along the lateral wall of the uterus. Okay. So if you have inserted copper T388, threads will not be visible. You will not be able to see the threads. If you see the threads, it means that it is not the fundal placement of the copper IUCD.
Yeah, thank you so much, Radhika. And I think that was fantastic because I wanted this PPIUCD video to show that if the technique is correct, the patient does very well with this method. Thank you so much. And we'll take
Thank you,
interaction from you in yet another forum. Today we'll go across to Kavita.
Yes.
Sushila, please introduce this
Yes, ma'am.
faculty from the north, Dr. Kavita Agrawal. I'm
Yeah,
very
Dr.
proud of these two girls,
Mhm.
Radhika and Kavita. Yes, please.
Thank you.
Yeah. It's pleasure to introduce Dr. Kavita Agarwal. She's Associate Professor, VMMC and Safdarjung Hospital, Chairperson Infertility Subcommittee, AOGD, Vice President IMA South Delhi Branch. And she has taken training in infertility from Rainbow IVF, Agra 2017. And she's National Correspondent Editor, Jogi 2017 to 20, and Organizing Joint Secretary, FOGSI Obstetric History Conference 2017. And she has been the winner of the FOGSI Dr. Kamini Rao Audition Award and many awards to her credit. And she has presented 17 papers and or posters in the conferences, and she has been faculty in more than 100 conferences. The stage is all yours, Dr. Kavita. Over to you, and she's going to talk on expanding the contraceptive benefit basket, Centromon as a valid choice for the post-abortal contraception. Over to you.
Thanks, ma'am, for the kind introduction. I would like to thank Dr. Lakshmi Shrikante and Dr. Shobha Gudi ma'am for having me here. I'll just share the slides. Are my slides visible?
Yeah, yes, Kavita, you can go ahead, Kavita.
Yeah. Yeah. So I'll be talking about evaluation of acceptability, safety, and continuation rate of Centromon as a post-abortal non-steroidal contraceptive pill. So this was the study done basically to stop this unintended pregnancies. If we see in 2015-19, there were 64 per 1,000 reproductive women who had unintended pregnancies, out of which 60% ended in abortions. Also, we have the data showing all over the world that approximately 10% of maternal deaths are due to abortions. So we need to put a full stop to this cycle of unintended pregnancies leading to unsafe abortions and leading to maternal mortality. So we came across this Centromon, which was synthesized in 1967, approved by DGCI in 1991, then was marketed as contraceptive in 1992. Then further, it was used in South America and also was launched in India in 2013, but it was marketed as post-coital pill. That is the emergency contraceptive pill. So finally, when it was marketed as an emergency contraception or the post-coital pill, so it was withdrawn by Americans and it was not further explored. So finally, in 2016, it was introduced as a contraceptive, as a weekly contraceptive in National Family Planning Program. And it was launched in 10 states that included Maharashtra, Uttar Pradesh, Madhya Pradesh, Rajasthan, Karnataka, Haryana, West Bengal, Odisha, Delhi, and Goa. So if we see its mechanism of action, it is a selective estrogen receptor modulator. And what it does is basically acceleration of the formation of blastocyst. And on the other hand, it suppresses the endometrial proliferation and decidulization. So there is asynchrony between the embryo development and maturation of endometrium. And this leads to prevention of embryo implantation. So now coming on to what we know about it. We already knew about its efficacy. If you see this recent, it was a review article which included 8 studies on centromen. Its effectiveness ranged from 93% to 100%. Also, they saw about the safety, which the prolonged cycles greater than 45 days was the most commonly reported side effect. And in the Indian national guidelines, also menstrual delay in 8% has been reported as the only side effect. If we see some studies which have found that the ovarian cysts, but what they found, these are the only studies which have been done till date, which followed the patients on centromen by ultrasound. And if you see here, there were 153 participants, 4 had follicular, 4 had corpus luteal cysts, and no cyst was bigger than 2.5 to 3 centimeter. Here there were 377 participants, out of which 64 had ultrasound, but there was only one patient. There were 2 patients who had enlarged ovaries, but on subsequent examination at 12 and 20 months, ovaries were normal. So what we see here by the studies, here 175 participants, that this was only a transient. So now we come to that conclusion. The studies have already proven its efficacy, its safety, but what we are seeing that since 1967, now we have come to 2023, it has not been used much. So when the studies have proven the efficacy and safety, in our study, we tried to evaluate the acceptability and the continuation rates to know what are the reasons. Is it really acceptable to the population? And if not, then why? And what are its continuation rates? So we did this study to evaluate acceptability, safety, and continuation rate of centromen, and we did it on the post-abortal women. It was done after ethical committee approval. It was a prospective observational study over a period of 2 years. We took all the patients who came to us in gynae emergency or family planning OPD. Either they came with spontaneous abortion or they came with induced abortion. That is, they had already taken MTP pill from a chemist, and now they landed to us in severe anemia or with heavy bleeding, or they came for medical termination of pregnancy in our family planning OPD. So any of these patients, they were offered contraception, all the methods which were available to us at Safdarjung Hospital, that is in the government supply. We had Maladi, that is the combined OCPs, Antra, Chaya, that is centromen, that is DMPA, Antra, copper T, and tubal ligation. So all these methods were given to them. There were certain inclusion and exclusion criteria. The inclusion criteria was that only abortions up to 20 weeks, and they were willing to use centromen for contraception starting within 7 days. So all those who were willing to use centromen, they were further studied to see what was their continuation rate, willing to continue centromen for at least minimum 1 year, and willing for follow-up. Exclusion were history of polycystic ovarian disease or any chronic liver disease, tuberculosis, and severe allergic traits. So detailed history was taken. They were advised how to use it. That is centromen as a 30 milligram tablet. It comes in 8 tablets in 1 pack. So 1 pack was given at one time, and then they were asked to come to collect the next tablets. So it was told to them for the first 3 months, they have to take twice weekly for the first 3 months. That is, they can choose the days, Sunday, Wednesday, or Monday, Thursday. So this is the way they are going to choose it. And after 3 months, they are going to use it weekly. And they were given, if you remember, I just now said 8 tablets, that is 1 packet was given to them. And if they had missed pill, but it was lesser than 7 days, then the normal schedule to be continued. But if more than 7 days, and they need to start taking it all over again. That is, again, they have to take twice weekly for the first 3 months, and then they have to take weekly. And they were advised to come to family planning OPD in case of period delayed by more than 15 days or UPT was done to exclude the pregnancy. They were followed up at 1 month, 3 months, 6 months, and 12 months. The questionnaire was asked, which included how was the compliance, how was their adherence to the regime, any side effects, any problems about the menstrual cycles, the flow, weight gain, or any complaints, or even if they had accidental pregnancy. So that was all recorded. The outcome variables were basically acceptability, safety, and continuation rates. The secondary outcomes was efficacy, missed pill, and any side effects. The statistical analysis was done. So now coming to the results. We had 206 women in our study period who came to us with abortion, maybe spontaneous, induced. I will be coming to the indications later on. So we had 206, out of which 32 women just refused to use contraception for 1 year. They wanted the pregnancy earlier than 1 year, so they were excluded. And these were the women who were nulliparous women, and they had spontaneous abortions. So they were excluded from the studies. So finally, we had 174 who were willing to use contraception and willing to continue it for 1 year. So now we counseled them, offered them all the contraceptive services we had. And it was shocking to see that everyone wanted only temporary contraception. So we finally went into depth into it, that what was the reason, that why all 174 only want temporary contraception, even though we had offered them tubal ligation, they had completed families. But then we found out that these post-abortal patients, many of them, they came to us with severe anemia because they had taken MTP pill from outside. And that was the reason that we ourselves were not offering to some of the women, because they come in the category of delay of sterilization. So these were 30 women who came under the category delay of sterilization, and we ourselves had to offer them temporary contraception, although they had completed family. And second was what we found, that they were young. They were either mostly nulliparous or primiparous, and that is why they wanted to delay the pregnancy only for 1 to 2 years. So they were mostly interested in temporary contraception. And then when we asked for temporary contraception, they all chose oral contraceptive. And the reason behind was ease of administration. And out of these 174, 145, that is 83% of the women chose centromen, and only 16% they opted for COCs. And these 83%, out of which 25 we were lost to follow up, so we could follow only 120 of them. So now if we see, most of the women, they were in the age group of 20 to 30 years, nullipara or primipara, mostly were studied till only primary school and belonged to lower middle class. And if we see here, more than 80% had induced abortion at the mean period of gestation 6 weeks. And the reason for these induced abortions was small babies, studying in college, financial problems, relationship problems, hyperemesis, or they had completed family. But now also, although they had completed family, we were not able to offer them ligation. So you see, the problem which came was that 85 out of these 98 had already taken MTP pill from outside. And 17% required emergency suction evacuation, and 15% had very severe anemia and required multiple blood transfusions. So the completed family, either we could not offer, or they were already feeling weak, maybe because of moderate anemia, or they had small children, or there were family restrictions. So we finally studied 120 women who offered centromen. So all 174 chose temporary methods. All of them opted for oral contraceptions because of the ease of administration. They didn't want DMPA, or they didn't want copper T, as there was a fear of a foreign body inserted, but they readily agreed for oral contraception. And 29 of them opted for COCs because they had a fear of forgetting centromen, as it is taking weekly. So we saw some group of women which had this notion that if it is to be taken weekly, we can forget it. But on the other side, we also saw the women who were not liking this daily intake of a contraceptive. So they chose it because of less frequent intake. They chose centromen and because it has no fear of side effects like weight gain. So this is what we found in the chosen, what the patient is trying to choose and what is the acceptability. But the main positive thing what we found out is that if we offer oral contraception, especially centromen, all the patients, they at least accepted contraception who really wanted to space the pregnancies. They all accepted it. So now coming on to the further results of the follow-up, we found that till 3 months, when they were taking centromen twice weekly, the menstrual frequency was normal. The menstrual flow was normal. And after 3 months, when they started taking weekly, then the menstrual frequency was infrequent, and in about 25 to 30% of the patients at 12 months, the menstrual frequency, that is the cycles, were prolonged and the flow was decreased. But that happened at after 3 months until 12 months when we did the follow-up. 2 patients only complained of nausea and bloating, took occasional antacids, and this was more frequent during the first 6 months and decreased with further usage. No other side effects were seen. So continuation rate for the first 3 months when they had regular cycles with normal flow, it was 100%. So it has a good acceptability. And now if we see the continuation rate was also 100%. And from 6 months, then coming to 12 months, yes, 5 discontinued at 6 months and another 6 they discontinued at 12 months. So the continuation rate was 90%, although the menstrual frequency, prolonged cycles, abnormal flow, decreased flow was seen in around 30%. But we were able to counsel and the patient continued. Out of 30%, 20% continued, only 10% dropped, and that too, 7 had irregular cycles and the 3 had non-availability, because we did the study when it was just launched, basically in 2017. So it was not available at various centers. Basically, the patients who came from the villages, they took 1 packet or 2 packets from us, and then they went to their villages and said, it's not available. And even they are coming from far off place. So non-availability was the issue at that time, which I'm sure is not going to be now. So now the issue is only of irregular cycles, which we were able to counsel the women, and they continued. So there was 1 case of user failure and 1 case of method failure, and both the patients got MTP with copper T380 insertion done. Pearl index was 1.67 per 100 women years. So 88% women were satisfied and would recommend centromen for contraception. And the main reason being ease of administration, less frequent intake, and no weight gain. Now, if we see the COCs, which were chosen by 29 women, their continuation rate was 100%. 3 women in the initial 3 months complained of occasional bloating, nausea, which used to be relieved by taking antacids. There was occasional breast discomfort, but none of the patient had weight gain, tightening of clothes, or untoward side effects. The acceptability, they were comfortable using COCs, had regular menstrual cycles with normal flow, and would recommend it to others also. Efficacy, there was no case of missed pill, user, or method failure with COCs in our study. So if we see the best time to have maximum uptake of contraception is post-abortal. We found 84.47% women opted and were willing to use for the next 1 year contraception. And the various studies have found maximum uptake of contraception in post-abortal when they compared it with postpartum or the interval period. And the reason being here, the patient is already suffering from suction evacuation, a traumatic, and also plus the several blood transfusions, and she does not want to go through it all over again. So she readily accepts it. And that too, just they have to take a pill, which is just twice weekly. They have suggested that post-abortal as the best time to offer all information and motivate for contraception. Now, if we come on to the best contraceptive, which is chosen by the patient. So they all accept it, and they don't leave our OPD or our wards without taking any contraception. That is, all women opted for oral contraception, out of which the patients, they preferred mostly centromen. because of less frequent intake and no weight gain. And the women preferred because post-abortal women are young nulliparous. If we see the other previous studies, they have also shown that 20 to 29 years of age, unmarried, nulliparous, higher education level, they mostly go for oral contraception. Whereas if we see National Family Health Survey 5, they found that the pill method is only seen in 5.1% women. IUCD in 2.1%, 0.6% injectables, and female sterilization forms the maximum chunk of 38%. The reason being, they are considering the whole population, and we are focusing at the post-abortal women. And the main lacking here is that the healthcare workers are not offering contraception to these women. If we see another study, they also found out the weekly dosing of centcromen. It is an additional advantage apart from no steroidal side effects. And it is specifically for women who prefer oral contraceptive, but they are not comfortable with daily schedule. So if we offer them a contraception which is non-steroidal, oral, and it's not to be taken daily, definitely they are going to accept it. So the key word is we need to offer them. Now coming on to the cycles, menstrual cycles, what we found in the first 3 months, 100% continuation rate with normal cycles and normal flow, which dropped to 90% when we go up till 12 months. The continuation rate dropped. Similarly, in the other studies also. The major reason for discontinuation was abnormal uterine bleeding observed in around 35 to 45% users, and that was after 3 months. So by all this, we go back to the studies and we found out what should be the dosing. What we found that when it is given at twice weekly 30 milligram, they had higher levels compared to 30 milligram weekly dosing after 6 weeks. But eventually with twice weekly dosing also, the levels declined to the steady state levels of weekly dosing. So this was a study done by Nityanand. He used both the doses, 30 milligram twice weekly, and studied the level of centcromen in the blood, of the active metabolite of centcromen. So he concluded that after 3 months, if you even give it twice weekly, it's going to be of no use because it's going to get excreted. So eventually, after twice weekly dosing also, after a time, there's going to be a steady state level. And this level is same even if you give weekly or you give twice weekly. So after 3 months, you cannot help even by giving it twice weekly. So what to do after 3 months? What we did is counseling. So counseling, and it really played a big role. 70% had actually no problem, 30% which had problem, out of which also if you counsel the women, they accept it, they continue it. So after that 20% continued it, only we were left with 10%. The Pearl index was 1.67%, which is comparable to the other studies. So if we see present study, centcromen versus COCs, 83% preferred centcromen because of less frequent intake and no steroidal side effects. And only 16% chose COCs because they had a fear of forgetting as it is taken weekly. So we had seen both the sides, and continuation rate was 90% at 12 months, whereas in COCs it was 100% because here there was normal menstrual cycles. So in centcromen, to have the continuation rate, we always have to remember that we need to counsel. And there has been no other study till date, as far as my knowledge, to compare the acceptability and continuation of centcromen with other methods of contraception. So I could not quote it here. The strength was that we only included the post-abortal women because the inclusion of postpartum lactating women can lead to confounding results on menstruation. Limitations were small sample size, non-randomized study, and because we could not divide the patients randomly, it was just that we offered all the choices and we let the patient decide whatever that you want to choose from the basket. Recall bias could have occurred in the follow-up. So to conclude, there is increased acceptance of contraception in the post-abortal patients. The key is that you need to offer it. It is safe, effective, and well tolerated. Sancromin has good acceptance due to ease of administration and infrequent pill intake, good continuation rate with infrequent menstrual cycles as the main limiting factor for its continuation. So along with offering, you also need to do counseling and follow-up. It's also equally important. It's a good alternative for women who prefer oral contraceptive but are not comfortable with the daily schedule. So we cannot leave them out. We have to bring them also in. So I recommend healthcare workers should offer Sancromin for post-abortal contraception. It can go a long way in spacing of pregnancies, decreasing unintended pregnancies, and breaking this cycle of unintended pregnancies, unsafe abortions, and maternal mortality. Thank you. Have a nice day.
Thank you, Dr. Kavita. It was a very thorough presentation. You have talked the Sancromin in and out because I think you did the study very well.
Thank
So
you.
100% appreciation to you. And then you have talked really to say each and every aspect so properly. And then I think everybody should have the knowledge about the Sancromin, how it has to be used, how useful it is. And then to say it is very less prescribed and we have to have the knowledge, we need to educate the patients, like now they're accepting the LNG-IUS, they're accepting the REMPA, all these things. So I think the knowledge has to percolate into the practitioners. That is what I think.
She has successfully expanded the basket of choice.
Yeah. Very true, Dr.
And Kavita, I just wanted to ask you, one thing is I must compliment your team. I wanted to ask you two things specifically, which has always bothered me. I must also highlight one thing that you omitted, though yours was a fantastic presentation. But in the next time you present, please bring in the green mech wheel, which was, released in June.
Yeah.
We had all gone there for doing that. I must share with our esteemed chairperson, Dr. Lakshmi, that Family Welfare Committee was part of the team along with the President Shanta Kumari, and Dr. Ashok Kumar was also there that time in Delhi. And the Sancromin wheel, that means Sancromin being included into the mech wheel. Correct. It's green in color and it is there in the MOHFW.
Yeah,
So
actually
now,
I prepared it from the paper which got published at the time afterwards the wheel came.
So next time you just introduce it into your presentation, because it will tell all practitioners that, to look at Sancromin's MEC criteria is now there, because we were all there in formulating the MEC criteria for Sancromin wheel. That was one of the highlights of the FWC committee during my tenure, that we participated in that very, very actively. And to tell you the truth, it is quite a universal method, excepting few situations. So I just wanted to tell you that the next step can be the use of Sancromin in medical disorders, where it is less researched. So far COC has had more research. Yeah, it's a more researched molecule. Sancromin is less researched. So probably we must look at those situations where its use has not been established. But I really compliment you. One of the situations is polycystic ovarian syndrome, where we freely use the COCs even as therapy. But for contraception, Sancromin has not been used there, because there is a fear that, there can be some adverse effect on the endometrium, etc. So we need to be more careful, but by and large, it's a very universally applicable and acceptable method. I really congratulate you, Kavita. I want Dr. Lakshmi to now give her remarks, and we may look towards conclusion.
I know we are already behind schedule. But Shobha, I must appreciate your choice of topics and speakers. They were really, really practical and useful. Today, you taught the correct way of doing female sterilization, then the medical legal aspects of the sterilization, no-touch technique of IUCD insertion. That is worth, showing to all our fellows and members. And now Sancromin, which I already said requires a lot of awareness amongst we healthcare workers. So superb. All the speakers were simply fabulous with lots and lots of practical take-home messages. So well done, Shobha. And you can announce the next Sankalpa webinar ka date and theme, and then we can wind up today's webinar.
I think I'm not yet ready with
Okay,
the
so we will announce, you all will receive our message and
so
email.
happy that today has concluded well,
No,
because
no.
this takes little more thought, and I must thank you, Dr. Lakshmi, for putting your faith in me and giving me this huge responsibility of through ICOG for sensitizing our fellows and members in the field of family planning. I must thank you.
That
I'm
is
really
much,
very
much
grateful.
needed, Shobha. And I'm so happy that we can contribute something towards the government of India's goals. And we can only make aware our members, and that is what we are doing.
Very. So on that note, I think we must end. Dr. Sushila, I think your wonderful inputs were not possible today. We will
That's okay,
definitely
that's okay.
bring you in as a resource person next.
Yeah, that's
I
okay,
can
Shobha.
see many seniors here, and I would like to check with Dr. Alka Kuthe if she would want to
Yeah, she's here.
unmute and
Anjali, Dr. Alka Kuthe ko co-host bana do.
whether she could.
Yes, ma'am.
Dr.
She has
Alka.
been very active on the chat, and I
Yeah,
would really
Alka?
like her to come in. And
Hi Lakshmi, hi Shubha madam.
Hi Alka, welcome.
Yes, wonderful webinar. Actually, I heard each and every part of, because I was a part of Government of India program, family planning program, and I have found centroman packets lying here and there, just not used. So I think today's webinar, if our PGs could have attended, but they are all busy in doing their emergency duty, but I can use presentation if permitted for these people, so that I can educate them.
Alka, we will be uploading the link on our ICOG website, and everyone can view and learn. Today's the recording will be shared on our ICOG website. Yeah.
That's a brilliant idea. That's wonderful.
Yeah. And once again, the method of non-touch, we do practice it because we have been taught. But many upcoming OBGYN, they just forget this important point. So again, that method of non-touch technique can be uploaded so that we can again tell these people to go through that technique.
Yes, indeed. Yeah, very good. So
thank
all
you,
in all,
thank you.
Yeah, thank you, Alka. Thanks for joining.
Anjali, you
and
can
for
stop
all your
recording. Yeah.
Thank you.
Yeah. So I think Shobha, let's say tata, bye bye. Good night to all.